Hello, learning course lecture number 1. Approach to the patient with pulmonary diseases, dyspnea, cough and hemoptysis, wheezing, stridor, additional symptoms, history, physical examination, inspection, palpation, auscultation, percussion, diagnostic evaluation, chest imaging, pulmonary function testing. The majority of diseases of the respiratory system present with cough and dyspnea and fall into one of three major categories: obstructive lung disease, restrictive disorders, and abnormalities of the vasculature. Obstructive lung diseases are most common and primarily disorders of the airway, such as asthma, chronic obstructive pulmonary disease, COPD, bronchiectasis, and bronchiolitis. Diseases resulting in restrictive pathophysiology include parenchymal lung diseases, abnormalities of the chest wall and pleura, and neuromuscular disease. Pulmonary embolism, pulmonary hypertension, and pulmonary veno-occlusive disease are all disorders of the pulmonary vasculature, although many specific diseases fall into these major categories, both infective and neoplastic processes, and can affect the respiratory system and result in myriad pathologic findings, including those listed in the three categories above. Here you see categories of respiratory disease. Obstructive lung disease include asthma, chronic obstructive pulmonary disease, bronchiectasis, bronchiolitis. Restrictive parenchymal disease includes idiopathic pulmonary fibrosis, asbestosis, desquamative interstitial pneumonitis, and sarcoidosis. Neuromuscular weakness includes amyotrophic lateral sclerosis, Guillain-Barré syndrome, myasthenia gravis. Chest wall diseases includes kyphoscoliosis, ankylosis, ankylosing spondylitis, chronic pleural effusions. Here we have pulmonary vascular disease, which includes pulmonary embolism, pulmonary arterial hypertension, pulmonary veno-occlusive disease, and vasculitis. Malignant diseases include bronchogenic carcinoma, which means non-small cell and small cell lung cancers, and metastatic disease. And at last, infectious diseases, pneumonia, bronchitis, and tracheitis. Disorders can also be grouped according to gas exchange abnormalities, including hypoxemic, hypercarbic, or combined impairments. However, many respiratory disorders do not manifest as gas exchange abnormalities. As with the evaluation of most patients, the approach to a patient with a respiratory system disorder begins with a thorough history and a focused physical examination. Many patients will subsequently undergo pulmonary function testing, chest imaging, blood and sputum analysis, a variety of serologic or microbiologic studies, and diagnostic procedures such as bronchoscopy. The cardinal symptoms of respiratory diseases are dyspnea and cough. Dyspnea has many causes, some of which are not predominantly due to lung pathology. The words a patient uses to describe shortness of breath can suggest certain etiologies for dyspnea. Patients with obstructive lung disease often complain of chest tightness or inability to get a deep breath, whereas patients with congestive heart failure more commonly report air hunger or a sense of suffocation. Here you see the picture of dyspnea. Here are afferent signals from chest wall mechanoreceptors, lung mechanoreceptors, and so on, and efferent signals from the central nervous system to the upper airways and respiratory muscles and diaphragm. The tempo of onset and the duration of a patient's dyspnea are likewise helpful in determining the etiology. Acute shortness of breath is usually associated with sudden physiological changes, such as laryngeal edema, bronchospasm, myocardial infarction, pulmonary embolism, or pneumothorax. Patients with COPD and idiopathic pulmonary fibrosis experience a gradual progression of dyspnea on exertion, punctuated by acute exacerbations of shortness of breath. In contrast, most asthmatics do not have daily symptoms but experience intermittent episodes of dyspnea, cough, and chest tightness that are usually associated with specific triggers, such as an upper respiratory tract infection or exposure to allergens. Specific questioning should focus on factors that incite dyspnea as well as on any intervention that helps resolve the patient's shortness of breath. Asthma is commonly exacerbated by specific triggers. Although this can also be true of COPD, many patients with lung disease report dyspnea on exertion. Determining the degree of activity that results in shortness of breath gives the clinician a gauge of the patient's degree of disability. Many patients adapt their level of activity to accommodate progressive limitation. For this reason, it's important, particularly in older patients, to delineate the activities in which they engage and how these activities have changed over time. Dyspnea on exertion is often an early symptom of underlying lung or heart disease and warrants a thorough evaluation. Here you see the Modified Medical Research Council dyspnea scale. On the left side, we have grades of dyspnea from 0 till 4 grade. 0 is consequently not troubled by breathlessness except with strenuous exercise, and maximum 4th grade when too breathless to leave the house or breathless with activities of daily living, for example, dressing or undressing. For cough, the clinician should inquire about the duration of the cough, whether or not it's associated with sputum production, and any specific triggers that induce it. Acute cough, productive or phlegm is often a symptom of infection of the respiratory system, including processes affecting the upper airways, for example, sinusitis, tracheitis, the lower airways, for example, bronchitis, bronchiectasis, and the lung parenchyma, for example, pneumonia. Both the quantity and quality of the sputum, including whether it's blood streaked or frankly bloody, should be determined. Here we have a diagram of cough. The causes of cough, there are origins and neurological pathways of the cough reflex. The causes of cough are laryngeal reflex, eosinophilic airway inflammation, esophageal bronchial reflex, gastroesophageal reflex, pharyngoesophageal reflex. Chronic cough, defined as that persisting for more than 8 weeks, is commonly associated with obstructive lung diseases, particularly asthma, COPD, and chronic bronchiectasis, as well as non-respiratory diseases such as gastroesophageal reflux and postnasal drip. Diffuse parenchymal lung diseases, including IPF, frequently present as a persistent, non-productive cough. All causes of cough are not respiratory in origin, and assessment should encompass a broad differential, including cardiac and gastrointestinal diseases as well as psychogenic causes. Patients with respiratory disease may report wheezing, which is suggestive of airways disease, particularly asthma. Hemoptysis can be a symptom of a variety of lung diseases, including infections of the respiratory tract, bronchogenic carcinoma, and pulmonary embolism. In addition, chest pain or discomfort can be respiratory in origin. As the lung parenchyma is not innervated with pain fibers, pain in the chest from respiratory disorders usually results from either diseases of the parietal pleura, for example, pneumothorax, or pulmonary vascular diseases, for example, pulmonary hypertension. As many diseases of the lung can result in strain on the right side of the heart, patients may also present with symptoms of cor pulmonale, including abdominal bloating or distension and pedal edema. A thorough social history is an essential component of the evaluation of patients with respiratory disease. All patients should be asked about current or previous cigarette smoking, as this exposure is associated with many diseases of the respiratory system, including COPD, bronchogenic lung cancer, and select parenchymal lung diseases. For example, desquamative interstitial pneumonitis and pulmonary Langerhans cell histiocytosis. For most of these disorders, increased cigarette smoke exposure increases the risk of disease. Secondhand smoke also increases risk for some respiratory disorders. So patients should also be asked about parents, spouses, or housemates who smoke. Possible inhalational exposures at work, asbestosis, silica, or home, for example, wood smoke, excrement from pet birds, should be explored. Travel predisposes to certain infections of the respiratory tract, most notably TB. Potential exposure to fungi is increased in specific geographic regions or climates. For example, Histoplasma capsulatum. So exposures to these regions should be determined. Associated symptoms of fever and chills should raise the suspicion of infective etiologies, both pulmonary and systemic. A comprehensive review of systems may suggest rheumatologic or autoimmune disease presenting with respiratory tract manifestations. Questions should focus on joint pain or swelling, rashes, dry eyes, dry mouth, or constitutional symptoms. In addition, carcinomas from a variety of primary sources commonly metastasize to the lung and cause respiratory symptoms. Finally, therapy for other conditions, including both irradiation and medications, can result in diseases of the chest. The clinician's suspicion of respiratory disease often begins with patients' vital signs. The respiratory rate is informative, whether elevated tachypnea or depressed hypopnea. In addition, pulse oximetry should be measured, as many patients with respiratory diseases have hypoxemia either at rest or with exertion. The first step of the physical examination is inspection. Patients with respiratory disease may be in distress, using accessory muscles of respiration to breathe. Severe kyphoscoliosis can result in restrictive pathophysiology, inability to complete a sentence in conversation is generally a sign of severe impairment and should result in an expedited evaluation of the patient. About palpation, the role of palpation is limited in the respiratory examination. Palpation can demonstrate subcutaneous air in the setting of barotrauma. It can also be used as an adjunctive assessment to determine whether an area of decreased breath sounds is due to consolidation, increased tactile fremitus, or a pleural effusion, decreased tactile fremitus. To detect unilateral disorders of ventilation, the symmetry and degree of chest wall expansion can be assessed during a deep inspiration by placing one's thumbs together at the midline over the lower posterior chest while grasping the lateral rib cage. Auscultation is most important physical examination tool. The majority of the manifestation of respiratory disease present as abnormalities of auscultation. Wheezes are a manifestation of airway obstruction, while most commonly a sign of asthma. Peribronchial edema in the setting of congestive heart failure can also result in diffuse wheezes, as can any other processes that causes narrowing of small airways. Wheezes can be polyphonic, involving multiple different size airways, for example asthma, or monophonic, involving one size airways, for example bronchogenic carcinoma. For these reasons, clinicians must take care not to attribute all wheezings to asthma. The bronchi are a manifestation of obstruction of medium-sized airways, most often with secretions. In the acute settings, this manifestation may be a sign of viral or bacterial bronchitis. Chronic bronchi suggests bronchiectasis or COPD. In contrast to expiratory wheezes and bronchi, stridor is a high-pitched focal inspiratory wheeze, usually heard over the neck as a manifestation of upper airway obstruction, such as, for example, cicatricial tracheal stenosis or post-intubational tracheal stenosis. Crackles or rales are commonly a sign of alveolar disease. Processes that fill the alveoli with fluid may result in crackles, including pulmonary edema and pneumonia. Crackles in pulmonary edema are generally more prominent at the basis. Interestingly, diseases that result in fibrosis of the interstitium, for example IPF, also result in crackles and that sound like Velcro being ripped apart, although some clinicians make a distinction between wet and dry crackles. This distinction has not been shown to be a reliable way to differentiate among etiologies or respiratory disease. The lack or diminution of breath sounds can also help determine the etiology of respiratory disease. Patients with emphysema often have a quiet chest with diffusely decreased breath sounds. A pneumothorax or pleural effusion may present with an area of absent breath sounds. Now about percussion. Percussion of the chest is used to establish diaphragm excursion and lung size. In the setting of decreased breath sounds, percussion is used to distinguish between pleural effusions, dull to percussion, and pneumothorax, hyperresonant nodes. About diagnostic evaluation, the sequence of studies is dictated by the clinician's differential diagnosis as determined by the history and physical examination. Acute respiratory symptoms are often evaluated with multiple tests performed at the same time in order to diagnose any life-threatening diseases rapidly. For example, pulmonary embolism or multilobar pneumonia. In contrast, chronic dyspnea and cough can be evaluated in a more protracted, stepwise fashion. About chest imaging, at first X-ray. Most patients with disease of the respiratory system undergo imaging of the chest as a part of the initial evaluation. Clinicians should generally begin with ultrasound of the chest or a plain chest radiograph, preferably posterior, anterior, and lateral films. Ultrasound is often readily available and can help rapidly diagnose pneumothorax, pleural effusion, and consolidation of lung parenchyma. Chest radiographs give additional detail and can reveal findings including opacities of the parenchyma, blunting of the costophrenic angles, mass lesions, and volume loss. However, many diseases of the respiratory system, particularly those of the airways and pulmonary vasculature, are associated with a normal chest radiograph. CT scan of the chest can also be useful to delineate parenchymal processes, pleural disease, masses of nodules, and large airways. If the test includes administration of contrast, the pulmonary vasculature can be assessed with particular utility for determination of pulmonary emboli. Intravenous contrast also allows lymph nodes to be examined in greater detail. When coupled with positron emission testing, PET lesions of the chest can be assessed for metabolic activity, helping differentiate between malignancy and scar. Here you see chest imaging, chest X-ray versus CT scan. Chest X-ray and computed tomography scan from a patient with emphysema, for example. The extent and distribution of emphysema are not well appreciated on plain film, but clearly evident on the CT scan on the right side. Here we have chest X-ray and computed tomography scan demonstrating a right lower lobe mass. The mass is not well appreciated on the plain film because of the hilar structures and known classified adenopathy. CT is superior to plain radiography for the detection of abnormal mediastinal densities and the distinction of masses from adjacent vascular structures. Pulmonary function testing, spirometry. The initial pulmonary function test obtained is spirometry. This study is an effort-dependent test used to assess for obstructive pathophysiology as seen in asthma, COPD, and bronchiectasis. A diminished forced expiratory volume in first second called FEV1 and ratio with forced vital capacity FVC, often defined as less than 70%, is diagnostic of obstruction. In addition to measuring FEV1 and FVC, the clinician should examine the flow volume loop, which is less effort dependent. The plateau of the inspiratory and expiratory curves suggests large airway obstruction in extrathoracic and intrathoracic locations, respectively. Here you see these diagrams. Here we have healthy lungs with green color. You see an inspiration and expiration. Obstructive diseases. Here we have emphysema, asthma, and restrictive diseases, lung fibrosis, here on yellow color. Next test, pulmonary function test called DLCO. Spirometry with symmetric decreases in FEV1 and FVC warrants further testing, including measurement of lung volumes and the diffusion capacity of the lung for carbon monoxide, called DLCO. A total lung capacity less than 80% of the patient's predicted value defines restrictive pathophysiology. Restriction can result from parenchymal disease, neuromuscular weakness, or chest wall or pleural diseases. Restriction with impaired gas exchange, as indicated by a decreased DLCO, suggests parenchymal lung disease. Additional testing, such as measurements of maximal inspiratory and expiratory pressures, can help diagnose neuromuscular weakness. Normal spirometry, normal lung volumes, and a low DLCO should prompt further evaluation for pulmonary vascular disease. This is a diagram of DLCO. ABG, arterial blood gas testing, is often helpful in assessing respiratory disease. Hypoxemia, while usually apparent with pulse oximetry, can be further evaluated with the measurement of arterial partial O2 and the calculation of an alveolar gas and arterial blood oxygen tension difference. Patients with diseases that cause ventilation perfusion, mismatch or shunt physiology have an increased DO2 at rest. Arterial blood gas testing also allows the measurement of arterial partial CO2. Hypercarbia can accompany disorders of ventilation as seen in severe airway obstruction, for example COPD, or progressive restrictive